Welcome everyone to Resiliency and Emotional Health breakout session. We are lucky enough to spend the next hour and a half with a wonderful panel of guests, and we also hope to hear from a lot of you. So next slide. All right, so we want to make sure that you are all limbered up because again, we're going to need, we want to hear a lot from you in the chat box. So we're going to ask you to just get started as what is your favorite technique to foster your own resiliency in self-care? So let's hear, what are your own ways for self-care that you like to do? I know this is a little bit harder because we found out from our first session that a lot of people are working from home, potentially in their PJs.
Oh, so they're starting now. Here we go.
Ooh, exercise, running, massages, meditation, and a good glass of wine. Yes. Oh, volunteering, happy hour. Yeah, being outside. Hopefully spring will arrive fully across the United States since we've had sometimes winter-like weather remaining with us. Journaling, good cup of coffee, great TV show, eating together outside. Yes, so thank you. It looks like you all are limbered up with some great ways to chat in and some ideas for self-care. So perfect if you'll continue to use that chat box through the session. Next slide, please. So here's where the journey is going to take us today for the next hour and a half. So we're going to start off with one of our parent leads, Diane Pickles, again, is going to talk about the work's importance. And then Carol Lennon will take us through the roadmap ABP, the change packet. And then we are going to have, again, some question and answers with the audience. And we have parent reflections. We're lucky enough to have a psychologist with us today to share her perspective of resiliency, and finally closing thoughts. So next slide, I'm going to hand it off to Diane. Thanks, Diane.
Thanks, Christina. So I'm just going to provide some context for, as Christina said, why this work is important. And I wanted to start by, this is not going to be surprising to people that, nationally we have a problem with the fact that we've got mental illness and emotional issues in our kids that is not being addressed or dealt with appropriately. I did a little quick research. National studies show that about 1 in 5 children and teens, all children and teens, not kids with special health issues, have mental illness, but only about a quarter of them are receiving services. And a survey conducted by the American Academy of Peds in 2013, so this is outdated now, found that 65% of pediatricians felt they lacked comprehensive mental health training, and 50% said they lacked confidence when faced with a patient who has a mental health issue. So, clearly we've got a problem within our healthcare system in addressing mental health issues. And we're failing to uncover, never mind treat, mental health issues in our general population. So add to the high rate of mental health issues that exist for all kids, the issues that we all know that are, how it's compounded when you've got a child with, extraordinary challenges caused by chronic illness, and the lack of training and lack of confidence among healthcare providers to address those issues. And you can see that we've got a big problem. And because we're not addressing these issues in healthcare, we haven't traditionally addressed them in quality improvement work either. And when we moved into phase 2 in NPC, many of us, particularly parents, I think, pushed really hard to say that these issues had to be part of our work in quality improvement. We know that kids are struggling. I would say that at Sisters by Heart, we hear all the time from parents of HLHS kids of all different ages that kids are struggling with anxiety, with PTSD. Parents are as well, older siblings also. And it's really not, as one clinician pointed out to us, it's not post-traumatic stress disorder. It's because the stress doesn't end. So it's really, continuing stress and trauma. But they're also struggling with depression, all kinds of issues. we hear from parents of older HLHS survivors and clinicians that are working with those older kids that the learning and cognitive impacts of the disease are taking a toll on their ability to be successful in school, in jobs, and in relationships. And I think that what all of us, parents and clinicians, feel so strongly about is that if we're giving these kids longer lives, but we're not giving them quality of life, then what's the point? Really, what's the point? And I think that it's not enough. I feel so strongly that it's not enough for the kids to survive. They have to thrive. And that's what it's really about. And in order to do that, we've got to provide social and emotional supports for them throughout the lifespan and for their families. And this work can't be an add-on. It's got to be integrated throughout all of what we do for these families and for these kids. And it has to be incorporated. And it can't just be about the work that parents do with mental health clinicians. It's got to be work that is shared by parents, mental health providers, cardiologists, surgeons, nurses, nutritionists, all the people that touch the lives of these kids. And so I think that's just some context for why this work is so critically important. I think what it really comes down to is that HLHS impacts every aspect of a child's life, of a family's life. We know that the learning and cognitive impacts of the disease are profound, and that it is having tremendous impacts in terms of causing anxiety, depression, PTSD. There's two quotes on the screen that I just, when I started thinking about this, this session, really spoke to me. The first one here on the left: life is not measured by the number of breaths we take, but by the number of moments that take our breath away. And I think that just speaks to the fact that it's quality of life instead of the length of our lifespan. That to me is just so important. And I think that that's what it's about. As you know, as I think about having a 23-year-old and think about the length of his lifespan, it's more important to me, and I think he would echo this, that it's the quality of that life that is more important than the length of that lifespan. And the second quote on the right there speaks to the fact that, you know, what you deny or ignore, you delay. What you accept and face, you conquer. And I think that that really speaks to the fact that if we ignore these issues and we don't face them early on, we're just postponing the fact that these problems get bigger. But if we can uncover them and help these kids deal with them early on and give parents and families the tools to help them deal with them, we can really help them conquer them and give them that quality of life, so that they don't just survive, but they thrive. So I think that's some context for why it's so important. And with that, I think I'm turning it over to Carol.
I think there were some pictures. Oh, I guess you are. Hi, thanks, Diane. It's appropriate. It's always hard to follow Diane's eloquence, but in this case, it's hard as usual, but appropriate because I want to tell you about a project that the American Board of Pediatrics is supporting called the Roadmap Project, and Diane was one of the key reasons that this is taking place, Diane and Stacy. And Diane, one of the hats she wears is that she sits on the board of directors of the American Board of Pediatrics. Stacy Lynn sits on the board of directors of the American Board of Pediatrics Foundation. In 2016, the board asked me, I serve as senior quality advisor, to bring together families. We actually did this in 2015, and here's the meeting in 2016, to really focus on how can the board work with families to accelerate their mission. And the board certifies pediatricians as being competent and excellent to care for children and adolescents. At this meeting, and Diane is there, I think Stacy connected by phone. Up in the upper left, you can see Jamie Rich, who talked at one of our face-to-face learning sessions. One of the things that came up at this meeting, and these, you'll see the group you're seeing there are parents from across multiple learning networks, one focused on adolescence and depression. One focused on sickle cell disease, autism, cystic fibrosis. There were, I think, 9 different networks represented here and 9 different chronic conditions. One of the things that happened at this meeting was the board has a strategic initiative on mental health. The board helps make sure that when clinicians are certified, they're qualified in certain areas. And Diane just mentioned that statistic that more than almost 2/3 of pediatricians surveyed had said they don't feel competent in mental health. So at this meeting, there was a sense the board wants to work on this, and the parents, I think one of the things that came away for me at this meeting was the incredible alignment across parents and patients with many different chronic conditions about the things that Diane just mentioned, that we really need to pay more attention to resilience and emotional health. After this meeting, the CEO is on the right there. 3 parents, next slide, wrote a letter, and I believe Diane was one of them, and Stacy probably one of the others, that said, we believe there's a valuable opportunity to work across chronic disease networks and address the important issue of emotional support and mental health for children with chronic illness. If the ABP were willing and able to invest resources, we might be able to truly generate a roadmap for new strategies and interventions. And with the rich working group that was in the room and patients and parents, you've got all the right players to co-design something that will benefit patients and families. To give you a sense of timeline, the meeting was mid-September. This letter was written in the next couple of weeks. The board of directors met a couple of weeks after that in October, and they said to the board, please make sure this happens. And so I was asked, I work with the board on different quality initiatives to put together a proposal that began February 1st, less than 4 months later. And that was February 1st, 2017. So what I want to do is share with you what we've done since then to begin, and I want to emphasize, begin to address that question. I want to share with you a rough cut of a video that we made. We used an opportunity of a meeting that was bringing together people across different networks, and this project is called A Roadmap to Support the Resilience, Emotional, and Mental Health of Pediatric Patients with Chronic Conditions and their Families. And I want to really give a shout out to Stacy and Diane, among others, other parents, because it was some of the work that's going on that you're going to hear about, that you heard about yesterday with the CARES resiliency effort, and with Diane and Stacy's roles at the board that I think really propelled this forward. So what I'm going to share with you is a rough cut. It doesn't have a title. We're still trimming it down. This started out being about 8 to 10 hours of video clips. We got it down to a small number, and now here's the what we think is going to be our very close to final. I'm going to ask that, just sit back and watch this, but if you can chat your thoughts before we finalize this, I'd really like to know if the message is getting across, what you think about it. And it'd be hard to do a lot more because a lot of it's been filmed, but are there some words? Should we cut things, etc.? So let us know as you sit back. And I think this will tell you, hopefully this will resonate with all of you. So.
Chronic conditions, chronic illness, for kids and for parents is really, really hard.
It's a life of constant worry, and And it's hard. There's some really, really hard times, and it's 24/7.
It requires constant 24/7 management. It takes no holidays. There's no breaks. It doesn't go away on your birthday. It doesn't go away because you go to Disney World. It's always there.
When you are raising children with chronic illness, you will feel overwhelmed. I mean, that's just a part of your story. It's a part of your journey.
It takes a psychological toll on you and the people surrounding you.
Traditionally, medicine and pediatrics has segregated behavioral health into the psychiatry realm and hasn't paid attention. But we're beginning to understand that if you don't, in fact, support behavioral health of children and their families, everything else falls apart.
Especially in chronic illness care when the specialty provider is really the primary provider.
We think some about the patient, we think a little bit about the parents, and we almost never think about the effect that it's having on the rest of the family, the siblings in particular.
There are lots of barriers to doing this. One is time.
There's also issues around feelings of inadequacy to address certain issues.
It's just lack of resources.
You are expected to be strong.
Sometimes we, as patients, kind of silo our concerns. And so if I'm going to the gastroenterologist, I'm only going to talk about everything from my mouth down and not my mouth up.
When we went to Children's, they recommended that my sons talk to a mental health professional. And first I'm like, they're not crazy, but I had to get past what I had learned, the stigma associated with seeking out a mental health professional.
It took me a long time to realize that it's okay to do something for myself and not feel guilty about it.
The principle of if you're on an airplane and you need to use oxygen, you always put it on yourself before you put it on someone else. But what I realize now is that until mama has what she needs, that baby can never thrive. We get to our pediatrician for the first time with all 4 children. And I walk in, I have one with a G-tube and oxygen. I have one child that's beeping because he hears the machine beeping. He's 3 and he's just beeping. And my pediatrician turned to me and said, "How are you doing?" And it wasn't the "how are you doing" where people are trying to get their papers and they're not even looking at you. It was stop everything, hold the line, how are you doing? That was the first time someone asked me how I was doing.
What would you do to make this better for another child? And my daughter looked at me and said, I wish that they would have listened to me and asked me how I felt about what was happening.
Well, how are you doing? How's your family doing? I would like that to be just like, you come in and they say, stand on the scale. You're taking your weight, you're taking your blood pressure. It would just be common practice.
There's the, hey, I'm Dr. Crandall, how are you? And there's, hey, how are you? This had to have been tough the last couple of weeks.
But if we start working with families from the time of diagnosis, very early, so that they begin to understand that their resilience is important for their child, that their emotional well-being is crucial for outcomes for the family and their child, then I think that the care team can take responsibility for partnering with families to achieve this.
Can we always provide everything that somebody needs? No, but can we do something better than nothing almost every time? Absolutely.
We need, in fact, to do this in a learning mode because we really don't know how to do this optimally. It's going to take persistence. Emotional behavioral health is really important for these families.
It's okay to ask for help.
I think we do our children such a disservice by not addressing all of the things that they're about and understanding all their needs and their dreams and their hopes. I mean, part of this is seeing the future and seeing a child who can do anything.
Roadmap means that not only are the families stronger, but the kids are better.
Great, Carol, thanks for allowing us a sneak peek at that video. So I'm showing my age a little bit, but I think you're kind of asking us, the audience, to be Siskel and Ebert, the guys that reviewed movies. So there's already a lot of thoughts coming into the chat box. Some people are really appreciating the multi-specialty representation in the video. People are even calling out specific people that they knew. So it looks like it really is a nice wide representation. There was a question from Kelly Kirby. She was curious, she commented that she loved the way the video addressed mental health stigma. And then she also was curious if you could talk a little bit about who the target audience was. Was it parents or providers?
Hi, Kelly. Thanks. I think Kelly's at Stanford. So, hi, Kelly. Great question. One of the things we're thinking about, well, the target audience, right now, this, and then what I'm going to talk about in a few minutes, we're trying to be fairly generic so that this video can be used in multiple settings. And part of this is resources. We're thinking about doing something separately for families that goes a little bit more into, it's okay to ask for help, and here's how we did it. Here's the things I do. The thought is that this could be used in settings like this to begin the discussion. The board is doing a lot of work with pediatric program directors, so residency programs, fellowships. We had a meeting a few months ago with something called the Committee on Pediatric Subspecialties. There's going to be a meeting next week where this will probably be shown to all the sub-board chairs of the Board of Pediatrics. The pediatric department chairs, Diane and I talked last week, thanks to Erica Sood at the Society for Pediatric Psychologists. So we tried to make this so that it balanced both multiple audiences, recognizing that we need to make this more specific. And I'm going to talk about some other resources that we're doing to develop this. So I hope that helps, Kelly.
Yeah, and you're getting a lot more positive comments in the chat box. It's funny, something you said, it's like you could see the comments, because Stacy, Lynn, there's so much chat blowing up that I lost your comment, but basically she could really relate to taking the time to take care of herself, not just her child. So a lot of positive feedback. And we have time. If any of our panelists would like to chime in, since you have the ability to unmute yourselves, and if something struck you about the video, we do have time if any of you would like to do that.
Christina, this is Diane. I think this is what Stacy was commenting on. I love the comment about the need to put your own oxygen mask on first. I just think that is just so powerful, and yet it almost goes against our instinct a lot of the time. It's counterintuitive, which is the whole point of why they say that on airplanes, right? Why they remind us of that on airplanes. Because it's our instinct as a parent is to do for our child before ourselves, and it does feel selfish. But it is so critically important, and I thought it was great that was in the video. And coming from that mom, with 4 kids, 3 special needs. So anyway, or four special needs.
4 special needs, yeah.
4.
Really was.
So really powerful.
I also thought it was very powerful to talk about the nonverbals of that communication with the pediatrician, that it wasn't a, shuffling papers, looking at the computer, how are you doing, how's your other child, but really stop everything, turn to the family, sit down and ask that question and wait for a response. And I think the response that a provider is going to get is going to be so different depending on how it's delivered. And so those nonverbals really need to be part of that discussion.
What was fascinating, Erica and Diane, is the same things kept being said. And we could only, we did it a little bit at the beginning where the first 2 parents say it's 24/7, and then the how are you came up just by various people. And it was, and I thought Robin's comment about, can you make this like taking a blood pressure? This should be what you're doing every time. So just trying, it was, I think both it was very reinforcing that people kept saying the same thing. And I think, Diane, when you were at the board, that's what we heard. You know, people were just, it's so common. So, so.
Great. Thank you all for
thanks. I'll look forward to seeing the chat feedback. So that'll be good.
Yes, there's a lot. We will definitely save that and share.
Thank you.
So I think you're going to continue on with
Yes.
how to build confidence to be able to build resiliency. So next slide, please.
So I'm going to tell you about this. And again, I want to say that we're really early in working on this. It's been 13 months. I think one of the things, and this is Stacy's family, there's Zoe, I think either after a cath or no, it must be after the Fontan. And I think in the lower right is after a cath when Emmy came. So really the sense, I think one of the things we've had in mind is we really need to focus on the patient and the family unit and not forgetting the siblings. So I just wanted to comment on that. Next slide. So what did we do besides make a rough cut video? So we worked across 9 chronic disease networks and we co-designed this change package, which I'll talk about, with patients and parents. We used a systematic process to make sure we understood patient and family needs. We did an environmental scan of the pediatric literature. We worked with patients and families across chronic disease networks, and we sort of paralleled what we do in our collaborative. We had monthly calls with patients and parents. We shared the key driver we were developing, questions, a lot of back and forth as we were pulling things together and making sure we were addressing what patients and parents thought was important. We also identified current strategies that were in use from networks, from partner organizations that were already incorporating a focus on emotional health. In the lower left, you can see one of the parent bulletins from NPC. In the middle is something that the Cystic Fibrosis Foundation has developed. And in the lower right is something that the Inflammatory Bowel Disease Group has done, their network. The two on the right see a lot of kids with who are teenagers. And so when we were beginning this, there was I remember thinking, well, this will be great. There's things going on that address this and we can learn from what they're doing. And I will say, you know, when you're starting something, you're always optimistic. I thought, well, this will be actually relatively easy because some networks are already doing this. And of course, you find out when you get into things that, you know, it's more complex. So next slide. And I think this is when we got the proposal in February 2017. I would say, here's what I wish I knew. We did a great job at co-designing this with patients and families. We did not include pediatric psychologists and mental health professionals as much as we should have, and they came in a bit later. And in fact, Erica, several of her colleagues were terrific at providing feedback on the first 35-page document that we developed. And they basically said, you missed all this literature in the ped psychology literature. So, and I think the other thing that I wish I knew was that, and I'm a pediatrician, so I think it was sort of natural that I thought, oh, great, here's this screening that's being done. We can just adopt this. And early on, when we were pulling this together, it was talking with Erica, Cheryl Brosig Soto at Wisconsin, and Adrian Kovacs at Oregon, that really helped us realize that if you just start down the road with screening people for anxiety or depression, that you're sending a message that probably something is wrong. and that you need to really lay a foundation, as one of the clinicians in the video said early on. So next slide. This article came out last summer as we were working on this, and Tom Boat, who was in the video, the older gentleman, or well, they both had grayish hair. So he really came out. He's a pediatric pulmonologist, and he said, you know, for my career, we focus so much on getting these kids' lungs, guts healthy, that we really weren't thinking about other issues for them. And I think he's spending this part of his career just trying to get this message out. He wrote this 2-page article, which we can make available. It's terrific, with a pediatric psychologist and with another pediatric pulmonologist. And if you just click, there's one comment in there. It says, current child health systems have responded vigorously to the physical health challenges of chronic childhood disease, but less consistently, or I'd say not at all, to the challenges of proactively supporting the wellness of patients and families. So next slide, please. So what we've learned is we need to start the conversation early. And Stacy Lynn really helped me. We gave a talk on this a while back, and I thank Stacy for a lot of pieces of this slide. It's really supporting regular self-care. And as Stacy said, it's an art form. Sleep, exercise, unplugging sometimes, mindfulness. I know that sometimes when I try to meet or connect with Stacy over the weekend, I don't hear back until Sunday night or Monday morning. So she really unplugs, which is something I need to learn from her. So developing clinic processes. Ongoing surveillance is this idea that in addition to screening, you're really checking in all the time with people and sort of setting the groundwork that it's okay to ask. The mom in the video who has the 3 preemies and the child with significant autism said because her pediatrician asked her that time, how are you doing? She said, we cut this, but she said, I knew then that I could always come if I needed to. And she said, I've actually done pretty well, but it just has made me feel like I have a lifeline if I need it. I think one of the things we've talked about in some of the NPC breakout sessions over the years is how do we screen and identify those who are at risk, both the children and the parents who are really struggling. So I think that's something else. The other thing is identifying resources, referrals, and what are the gaps, and thinking about that at a center level so we can have things in place. Next slide. So we developed, this is very QI, a change package to support the resilience and emotional health of patients and families. The first one was done in last September, 35 pages. We put it out to the patients and families, pediatric psychologists, clinicians. We got tons of feedback. We had a meeting and really developed a lot of ideas. And we've now revised it. It's very close to being final. It's much more compact, only 25 or 26 pages. It's generic, and we did that purposefully so that it could be useful across many chronic conditions. It provides specific strategies for subspecialists and families. It gives some examples of metrics for networks and other organizations to assess and monitor their efforts. If you were in the CARES Resiliency breakout yesterday, you saw how they're taking what was done and really developing some nice metrics for us to look at. And then the other idea is that this provides a foundation for the adoption of network or other organizational initiatives. When we shared this change package at the meeting, at the board, the follow-up meeting last October, one of the subspecialists said, we had parents talk and then shared this. He said, you know, this is all really terrific, but could you write out some scripts for us? How do we get this started? And So one of the things we're doing now that we finalize this is we're developing some one-pagers, and I think for clinicians, it'll be a little bit of a crutch, and then I think their inner human will come out and they'll know. But right now, it's really, people want to help, but they're not sure how to do this. So I think part of what we're going to be doing is developing this, putting it out there, getting feedback, and I think over the next several months, we hope to have this ready. Next slide. So we came up with, I'm going to hand this off in just a minute. We have just a couple more slides. We developed a change package with, of course, key drivers. So let me just read these so that you know how we thought about this. It's really important to make patients and families aware and clinicians aware of the importance. So starting maybe not at diagnosis, but really shortly after that first meeting. And I think there's even words that can be said there. Diane noted we need to provide some care team clinician know-how and confidence to support them. I think that's what we were asked with the script. How do we have this conversation? Patients and families, how do we help foster their resilience? And what are some things that we can do? Peer-to-peer support. Because of Sisters by Heart, I don't need to say anything more on that, but we clearly know the value of that. How do we help clinics build in surveillance, assessment, and specific screening into the visits? And then how do we ensure that resources are available and accessible? There aren't enough pediatric psychologists or social workers, so what can the clinicians do? You don't have to be a mental health expert to do this. Next slide. So where are we going with this? The board, yesterday we submitted a proposal to continue this work for 2 more years. Right now we're working on developing a communication plan. The video, I think, Kelly, will be a way to increase awareness, build will, and a sense of urgency. We're developing several resources, the short video. We're developing specific scripts and short materials, both for families and for clinicians. And we're going to be putting up web pages on the board site. People don't typically go to the board for this. We're going to be putting it up on our general network of network sites and then sharing this with all the different networks. And we hope the Academy and others will post this. And then we're going to be developing blog posts, helping people with websites, PowerPoint, so you can do grand rounds, you can give a talk on this. And what I didn't put on here, we're putting in some funding so we can take the show on the road and have some clinicians and parents really talk about this at key meetings. And, as Tom Boat said in the video, it's going to take persistence. So we want to make sure we work on that. And I think that might be my last slide. So. Yeah.
Perfect. Thanks, Carol. So we do have a couple minutes for questions. If anyone has any for Carol, we do have one comment in the chat box, Carol, from, from Sherry Smith. And her comment was about resources and that she was actually recommending one, that there's a growing group of professionals who work with adults with ADHD, and they already could have helpful tools for dealing with problems that some people just don't understand. So that was a recommendation that she had.
If she can send us that link, that would be good. Maybe she put it in there. So I don't know. But Sherry, if you can send that in, that would be helpful. Thanks.
Thank you, Sherry. And you can use that info at NPCQIC, and we will get that to Carol. And then, actually, can we unmute Andrew Van Bergen and his team? Because he has a comment in the comment box.
Andrew. Hi, Andrew.
Are you ready for that?
Oh, sorry, I'm putting him on the spot.
We'll see. Will it be presented for payer?
I'll read it for him.
Oh, here, hold on. We just got him. Andrew?
Hi. It's actually not Andrew. Andrew's team. Andrew's team, yeah. Andrew's in the surgical meeting.
Okay.
Oh,
But it's the other half.
did you want to pose your comment or question and give a little bit more richness to that comment?
We were just thinking about, I mean, I think this is wonderful that it's coming from the American Academy of Pediatrics. We all do. I guess next steps would be getting the, how do we lobby or get funding so that mental health will be covered for the families?
Yeah, great question. So this is coming from the board, which is a different organization than the academy. We had representatives from the academy there. The academy is a 65,000 member organization of pediatricians, and I think there are affiliate members such as nurse practitioners. The board is a certifying organization, so really trying to make sure that that people have the skills to be good pediatricians. The board just sponsored a meeting last week, I think, or 2 weeks ago, in DC, had insurers there. It was at the National Academy of Sciences, had some people from the government. So we know that advocacy is really important on this. It's not something that the board and roadmap is going to take up. It's sort of out of our scope and skill set, but that's something that other people at the board are connecting in a very broad. They've said that they'd like this project to be part of a roundtable of people working on this issue in pediatrics. So I think we'll be getting to that, not through this program, but knowing that that's a key issue. They had somebody at their meeting from CMS, and then they also had someone there from Blue Cross Blue Shield and other groups. So.
Oh, that's great. Thank you for clarifying. And if there's ever anything when we get to that point that we can advocate for to help to get that coverage, please let us know.
Well, you guys are Advocate Health after all. Yeah.
Thank you.
And I'm happy to answer the next question if you want to read that question or if you want me to. The question was basically if any of sites have dedicated mental health teams for children and families with chronic illness. And pediatric psychologists, this is what we do. This is our field. I would say many, certainly not all, but many children's hospitals do have a psychology department or a behavioral health department. How those pediatric psychologists are funded does differ. So some are funded by the psychology department and then liaisons to the medical departments. Others are actually funded within and embedded within the medical department. So I'm a pediatric psychologist. I'm embedded within cardiology. So cardiology pays 80% of my salary. So there are many hospitals that have this, and I would certainly advocate for it.
I'll just say, and then I know we probably need to move on. That would be optimal. And I think we're also trying to make subspecialists more comfortable with this so that, as one of Erica's colleagues said, you don't have to be a mental health professional to make a difference and to communicate. So I think we probably are going to be working on this in several fronts. Trying to ensure there are these terrific resources like Erica, Adrian, Cheryl, on sites, Kelly, and then trying to help clinicians just be more comfortable at talking about this and bringing it up.
Thank you. So I'm going to go ahead and ask you to advance the slide not once but twice. I want to be mindful of time. We're having such great discussion. We only have 45 minutes remaining. I want to make sure we have time for our panelists. So if you could skip to the next one too, sorry. We'll go ahead and start hearing reflections about this topic by both of our parents. So Diane, if you could talk to us a little bit about why this work was important from your own experiences as a parent.
Sure. Thanks, Christina. And thanks. You can pull that slide up. So I'm going to talk to you a little bit about my family's journey with HLHS and mental health that'll answer the question of why you'll understand why I think this work is so important based on our experience. So I'm going to talk to you about my first exposure to mental health support, and I'm going to use that word in air quotes here. So my first exposure to mental health support was when I was in the active throes of labor with Jake. And a nurse insisted on bringing in a social worker, even though I had said no, thank you. And that social worker proceeded to tell me that we had done the wrong thing in telling our Matthew, who was our older son, who was 3 at the time, that his baby brother was sick. That had been she said, what have you been telling him? We said we had been telling him that his baby brother was sick. And she proceeded to say that was exactly the wrong thing to say to him because, I don't know, for a billion reasons. And she was clinically or professionally probably exactly correct, but her timing could not have been more unhelpful. And I kicked her out of the room, and I took myself by surprise and Bill by surprise, and I'm sure her by surprise as well. It was completely unlike me. And in fairness to me, it turns out I was like in transition and ready to start pushing this baby out. And so I was very rude, but her timing was completely unhelpful. And I had not asked for her to be in the room. My second exposure to mental health support was when a cardiac intensive care unit nurse called social work, unbeknownst to us, and told them that they needed to come visit us because I wasn't crying enough and therefore I was not bonding with my baby. And I had 3 months to prepare for this baby, first of all. It's not like I was, thrust into this diagnosis. And I sobbed everywhere, but I did it in private. I just didn't cry in front of the nurses and doctors. And when I found that out, that was why social work was coming to visit us, I was a mixture of horrified and scared to death. And I was really terrified that it meant, I don't know what I thought it meant, but they might take my baby from me. I don't know. And I was angry. But based on those 2 experiences, I developed some significant trust issues around mental health. And I inherently really believe in mental health counseling and support. And I really did at the time, but not for myself. And that was really it. That was really the extent of any mental health support I was offered or provided. And in 23 years of, critical complex care for Jake, with amazing physicians at a top-notch hospital. We were asked at every visit, I'm sure, how are you? But never in that way that would have elicited a true depth of response. And we were certainly never asked how he was coping emotionally, socially, mentally. We were never asked if he was anxious or depressed. And I want to be clear, really crystal clear. I don't think that was because our doctors didn't care about the answer or didn't care how he was coping. And I think we looked like we were doing fine. And I want to even go a step further and say, I think I pretended that we were fine because I think I was scared to pretend to look otherwise. And when they said, how are you? I said, fine. But I can assure you that there were a lot of times when Jake was really struggling for a lot of different reasons. So he has this immune deficiency and he was sick all the time. He was missing tons of school and he was struggling academically very, very profoundly. He was cushingoid from all the steroids he was on from his asthma. So he was overweight, and that was really impacting his self-esteem pretty significantly. He wanted desperately to play sports like his older brother, and he couldn't because he couldn't physically keep up. He could be hilariously funny, but he could also be very angry and moody. And our life was utter chaos from the time of his diagnosis all the way through because of his chronic illness. And so we were in and out of doctor's offices and all of that. And we had to cancel pretty much every vacation trip, anything we ever planned. And as I said, the academic struggles were so profound. So I will say to you that although, his half a heart and his immune deficiency were so significant, the mental health struggles were more painful to watch and harder to deal with because we had no support in dealing with them. I think that there's been, those of you who heard me talk yesterday, heard me say that Jake's incredibly resilient, and we've been so blessed with that. But, it could have gone way worse in 100 different ways. It could have gone south, I would say. And he's really been impacted very tremendously in terms of mental health issues. I know he has struggled with anxiety and probably some depression at various times. And I think that the greatest challenge for him was just about a year ago when he failed out of college as a senior. And people don't fail out of college as a senior, typically. And he came home depressed and drinking too much. And it crushed my soul as a mom to see him come home that way. And I will tell you that it was my darkest time as a parent, because I felt we had all completely failed him. I felt it was completely preventable. I think that had he had proper emotional support, academic support, learning supports, all of it along the way, he would have succeeded, and he would have been able to get it together and be okay. He's resilient. He's picked himself up. He's gotten it together. I'm profoundly blessed and grateful for that. But the pain that he experienced could have been avoided if we had had some proper emotional supports along the way. So that's why this work is so important. These kids can't just survive. They have to thrive. And the pain of their half a heart, the physical pain of that, is more than enough for anyone to bear. They don't need the emotional pain as well. And if there's anything that we can do to lessen that, we are obligated to do it as parents and as clinicians. So that's my family's experience and why I feel so profoundly obligated to share that story, which is hard to share. But that's why it's so important. So with that, I will shut up and turn it over to Richard.
Thank you, Diane. So, Richard, we're looking forward to hearing your experience as a parent, and specifically what you wish your clinical teams would have known, or what could they have done differently or more of to support you and your family.
Well, thanks, Diane. And, it's just interesting to me that so much of your story yesterday and today is, so much the same as our story, but these are not the stories that we ever talk about. We don't talk about the mental health story. We don't talk about those struggles. We don't talk about the challenges of parents that much. And yet we must all be experiencing at least some of them. So to introduce myself, I'm Richard James. I'm Lucy's dad. You can see Lucy in these pictures. We'll talk about the context of those a little bit. So Lucy is 18, born on Christmas Day, 1999, and diagnosed with HLHS 2 weeks later after basically a routine well child visit to the pediatrician. Now, I'm just going to clarify real quickly that I'm going to refer to Lucy with they, them pronouns throughout the presentation, because that's their preference. And I'm only saying this because when I use this in conversation, sometimes people say like, oh, do you have twins? But no, we only ever had one kid. And, really after our experience in those first years, we really never considered having another kid. So after the devastating shock of that initial sudden diagnosis and admission and treatment, frankly, Lucy's medical surgical story has been fairly uncomplicated, at least by comparison with a lot of people. In fact, there were really years when we could almost have persuaded ourselves that we were over HLHS, certainly until the last few years. We always had a supportive family. The family lived locally. We always had good employees. We always had excellent insurance, although we didn't know until a couple of years ago that Lucy would always have been eligible for Medicaid. And, one thing that we've learned in the past couple of years is that the superiority of Medicaid emotional health and psychology coverage has far exceeded any of the private insurers that we've had. But, we always had those tools close to us. And Lucy is, generally happy, fairly healthy, smart, talented. They're passionate about theater. You can see here that's in the middle. If you don't recognize Aubrey Plaza from Parks and Recreation, you know, Lucy met Aubrey at an event last year because Aubrey is a Delawarean. You can see Lucy as Michael Banks in Mary Poppins, which was the final show of their high school drama career. And there's some, you know, other pictures, of course, top right. You know, we were very blessed to have Dr. Norwood working at Nemours when Lucy was initially admitted, and, you know, he did their surgeries, you know, throughout the stages. But, you know, and sort of this all sort of culminated, you know, this drama career, this story of success and relative health. Last week, Lucy accepted a spot in the Mount Holyoke class of 2022, and so we'll be taking them up there in a few months. But Lucy's also struggled for several years with anxiety and depression, you know, treated with medication and counseling. They've had episodes of self-harm. They've had episodes of substance abuse. You know, and myself, speaking of myself, I really spent, you know, many years just assuming that they weren't going to live, you know, and I still, to some extent, assume that I'm going to survive Lucy. You know, I saw a saying, a quote recently, adult medicine is the result of what was present but not seen in pediatrics. So resilience is a concept about balance. You know, I talked a little bit about what we had going for us. There's some more recent Lucy. The picture in the middle is Lucy's first day of the last year of high school, and holding a picture of Lucy on their first day of kindergarten, you know, just sort of crossing the lifespan. There's Lucy with our old dog Harry, Lucy recently in a portrait. So the balance, you know, there needs to be enough resilience on one side of the scale to outweigh the challenges that are coming in on the other side. As I mentioned, you know, we had a really strong kinship network that were very supportive. The economics was very much in our side. And so we had all of these resilience building factors just as really mostly as a consequence of sort of privilege and good fortune. And we didn't have as many challenges. You know, Lucy's health was, you know, physical, surgical outcomes were good, cardiac was good, you know, and until recently, you know, we've faced a different set of problems that have shifted the balance a bit because we didn't have the same, you know, resilience factors. You know, everybody's happy to talk about and chip in when you're going into hospital for 2 weeks. You know, we could have somebody come and take care of our house and our dogs and, you know, get time off work. And there's not such a level of comfort and familiarity in saying like, hey, you know, Lucy's really anxious and depressed, you know, you know, is there anything you can do to help? The toolkit isn't the same. So, you know, I noticed in the movie, you know, we're expected to be strong, and somebody mentioned that, but it's not enough to just be strong because even the strongest people can only carry so much weight. Resilience isn't the same as being strong or pretending to be strong. But I was at a meeting recently with another group where a parent was describing their sort of philosophy and their experience with her daughter's healthcare as, you know, like being in a sea with the waves. Sometimes you can ride them, sometimes it's fun, you're surfing, sometimes you get battered, but, you know, you learn, you know, she said you learn how to float. You recognize that the waves are always coming, that they ebb and flow, that sometimes they're weak, sometimes they're strong, but you know, you float, you develop those skills. And I really sort of had to stop myself from saying that, you know, what she was also describing was how people drown. Sometimes the waves are too strong, they're too high. You know, you couldn't afford swim lessons when you were a kid. You're carrying a load that you can't let go, but it's dragging you under. Some people have life jackets. Some people are looking at the lifeguard who can help them out. You know, they're not, it's not enough to be strong. You know, we're expected to be strong. We're expected to cope, to not complain. There's this sort of prevailing myth that our challenges are like ennobling or, you know, they're redemptive, but, you know, that we're not given more than we can handle. And you hear that a lot. There's a lot of sort of quotes and posters in various cardiac units about, being strong in the broken places, about, not closing a door and opening a window. But, I believe that, I am and have been profoundly damaged by the experience of lucid illness, but not as much as they have been. But, there was never an option to walk away that I could see being livable with. And, I always coped by, loving Lucy really extravagantly, even if that's expected. And even when I expected at some point that might result in, having my heart broken. We know from some, this is us celebrating Lucy's college acceptance at the top. We were on we just came back from a vacation in Amsterdam. That's me photobombing Lucy's junior prom. Lucy holding up a sign for me at the Today Show in Times Square when I turned 40. We went up for that. The best documented, this is another quote, the best documented asset of resilience is a strong bond to a competent adult. And this is why, we need to look at our own mental health support, even if we can't do it just for ourselves, even if we can't be that self-interested, there's so much evidence that our competence and our support and our mental health is a huge indicator of, the resilience of our children. Some of these pictures above, as Diane mentioned yesterday, we also, we didn't let illness define or restrict Lucy's experience to the greatest extent possible. So Lucy ice skated, they took riding lessons, played volleyball and junior varsity at middle school. We were able to do these things. We're fortunate, we're economically successful, we have resources, we have all these supporting things that enabled us to create opportunities for Lucy that are resilience building. I'm not even sure today how much they identify themselves with their heart condition. But, from the quote I mentioned about the best documented asset of resilience, also said children need opportunities to experience success, to have life experiences, to win at things, to triumph, to have competency, to have, that builds self-esteem. That is in itself a resilience asset. And one of our jobs as parents is to create those opportunities. So Lucy's emotional health and psychological health is, I think, at this point, much more significant in some ways than their cardiac health, certainly in the past few years. There certainly are more meds for anxiety and depression than they are for anything to do with their heart. And anxiety and depression has also been much more disruptive to relationships, to family dynamics, to school success, to other areas than cardiac health almost has ever been. Lucy wasn't probably ever going to be unscathed from mental health, with or without HLHS. My father was severely mentally ill for many years. My mother-in-law has an anxiety disorder. It really, runs in the family. Mental health is a multifactorial issue, but, it seems pretty sure from emerging research that it really was exacerbated by Lucy's health condition. Any of those, predisposing factors, were probably brought out by the trauma of hospitalization, by the stress of living with a chronic illness, by things that we don't really know what the factors are, and that this initiative offers, the chance to explore the connections and propose remedies. Is it hypoxia? Is it anesthetics? Is it repeated traumatic experiences during hospitalization? Does having a chronic illness subconsciously affect our modes of parenting in ways that we can recognize and address? As we start to see those connections to mental health, it will really sort of enrich the toolkit that's going to help our kids emotionally thrive as well as physically thrive. Just for a last comment that I have, I've become increasingly interested in the past few years in trauma-informed and trauma-sensitive care. There are obvious equivalences between our family's experience of trauma, and it's almost the same as violent trauma, as people who've experienced other kinds of violent incidences or assault. When our family arrived at the cardiac center, we felt like we had enormously failed Lucy, that we'd failed as parents, that we'd missed out on sort of critical health issues, and that Lucy was really, facing death because we'd screwed up, we'd put them at risk. And so we had to surrender all of our autonomy to the care team. We had no power at all. We couldn't feed, comfort, care for Lucy anymore. And there was one incident where Lucy's nurse gave them a pacifier, and we had, we were those parents, we were co-sleeping. We were not going to do a pacifier. We were going to feed on demand. We were going to do all those good things. And we walked out of the room. 5 minutes later, we walked back in, and Lucy was sucking on a pacifier. And I bore that grudge for years, because we didn't want healthy Lucy to have a pacifier, and we reacted really badly to that. So if, just to wrap up, if mental health impacts are part of this predictable clinical course, and it seems certainly that they are, and that they can be addressed by resiliency, building assets, psychological, social, emotional care bundles could be created and integrated into family-centered care, as much as anticoagulation, because, you hear from a lot of people, a psychologist came in, a social worker came in and said, is there anything I can do for you? And they were like, oh no, we're good. We're not that kind of family. We don't need that kind of care. And, all of us at that time, we didn't recognize that we did. It's almost, if a physician had come in and said, Lucy needs to go on digoxin, and we were like, no, we're not really a digoxin kind of family, that would have been kind of absurd. And, in some ways, maybe we should have had the same response if we'd have turned down mental health or psychosocial care. So just to wrap up my comments, there's a lot out there. We can learn about brief mindfulness interventions, and, nurses and clinical staff can teach those and recommend them. We can, almost insist on mediated connection with support groups prior to discharge. So that can be built into discharge plans to make those connections. We can connect people who need it through screening, because the screening tools are all out there. The diagnostic tools exist to recognize, which people might need more, intense interventions in this area. Everybody needs something, they just don't know it yet. But, social work referrals, individual therapy, there's an opportunity to develop, a real evidence-based model for establishing that psychosocial health model of care for HLH families and, other families with chronic conditions. And the impact would probably be enormous. So, that's our story. Thank you for listening. And I think we're going to move into another section.
Yes, thank you so much, Richard, for sharing your story, Lucy's story, your family's story. Both your story and Diane has struck a chord with a lot of members of our audience, particularly that facade or public front to be strong. So what I'd actually like to do is some of our next presenter may actually tie in to some of the questions that are coming in the chat box. So I'm going to change things up and immediately go to Erica, and then how much time at the end we can allot for, but I feel like Erica's going to answer some of these questions that are coming in. So if we could advance to the next slide. So Erica, how do you think, or what is the role of a cardiology clinician in promoting family resiliency? And
so I can start with that. I mean, I think I'm going to keep this brief because I think there's nothing that I can say that is more powerful than what you just heard from Diane and Richard. But what I really want to reiterate is that I think this needs to happen early and frequently. So from the work that I've done, the research that I've done, what's coming up over and over again is that parents, they feel prepared for, once they get the diagnosis, what does that mean physically? What physically is a diagnosis? What's the typical surgical course? But what they're not prepared for is, how is this going to impact our family? And in some cases, I think there's really no discussion about that early on. And that's impacting the child, impacting the parent, impacting marriages, relationships, siblings, finances. And so, this really needs to be weaved in much earlier so that parents don't feel blindsided and they can be prepared. And then they can also feel like this is something that they can bring up to the provider later on and say, remember how we talked about that? This is something that I'm now experiencing. And I think we've seen this with cardiac neurodevelopment. I'm just thinking about this, 5 years ago, I think we didn't do a great job of preparing families for some of the developmental challenges kids were going to have. And I think that's changed at a lot of centers over the last 5 years. And now I have families coming to me and saying, remember, 4 years ago when you mentioned that there were higher rates of ADHD and that my child might have this? I think we're seeing that. Can we talk about that? And they're the ones that are actually bringing up the conversation. They're calling me. And that's really different and really important. So I get calls from families who say, I might be concerned about autism. You said I could reach out to you at any time. And I always think about, what would have happened had they not had that contact person, because trying to navigate the mental health system is just impossible. So, I think we can do the same thing for some of these emotional health issues. We can provide, a contact person for them to call if they have concerns about anxiety or depression. We can open up the conversation early to know that these problems are common, not only in the children, but also in the parents. So I think, if there's anything I want to emphasize, it's really early and often. But that doesn't mean it needs to be a whole 10-minute conversation. It could be one sentence, 2 sentences at each appointment. And in terms of how parents can promote resiliency, I think probably the best thing to do is just to talk about it. And not every family is going to be comfortable with that. But if you're not bringing it up to your providers, they actually don't know it's a problem. If they don't hear from any family that they're having any mental health issues, why ask? And so I think it's actually up to the parents also to start that conversation. So really, I think, everybody has responsibility here. Also, I think with the role of parents, I think it's a great time in that we're starting to develop some of these tools to start these conversations. So, the roadmap project scripts, the bulletins for the Patient and Family Support Learning Lab. And one of the most important things to do is really partner in that and, give us your feedback and help us to write them because, we don't, as clinicians, have the expertise that you have. We don't know exactly the right answer to this. We don't know how much we should say when, we don't want to overwhelm families, but at the same time, we don't want them to feel unprepared. So what would you have wanted to know early on? How often would you have wanted to hear it? And so that's, getting involved with some of the learning labs around these initiatives is really a great way to help.
Erica, this is Carol. I was with the thing you said, how much to say when. It probably varies by individual and family too. So it's like another piece in there to, to be thinking about.
Absolutely. And it's so some of the research I've done, we've asked the question to parents from about 60 different care centers, whether they would have wanted to have mental health screening and whether they would have wanted to, be offered to meet with a therapist. And I think what's really struck me is how different the responses are. So it's about a third of parents say, I don't want you to screen me. The focus should be on my child. I don't want to take the focus away from my child. And I don't know to what extent that's also because they've been almost conditioned to respond in that way, right? If a care team acts as though their role is only the child, then that's of course what parents may feel is if I talk about myself, it's going to take the attention away from my child. And then there's about a third of parents who say, what, I don't think I'd want to complete a screening measure, but I just really like for a provider to acknowledge how hard this is and ask how I am. And then there's another third that says, I needed a screening tool. I needed, somebody brought up similar to a pain scale, but a stress scale or an emotion scale that's at the bedside that parents can just circle and say, here's where I am today. And then people know that, maybe that's the time for the social worker to stop by and have a longer conversation. There's parents that say, we needed coping skills, we needed therapy. I would have utilized this. And so I think that's where it's really challenging is how do you know it can't be a one-size-fits-all model, but it has to be available and it has to be offered. And families absolutely have the right to say, no, thank you. And we can't get upset by that. But again, even just offering it brings up the topic as something that is that can be talked about. And that, you know, if that's not something that they're experiencing or wanting at that time, that's completely fine. But 6 months later, they get home, and they may realize that, hey, you know, those things that I was asked about or were offered to me in the hospital or at an outpatient clinic visit, now I'm starting to feel those things, and to know that that's normal.
Thank you, Erica. So we continue to have a lot of comments in the chat box, and I just want to share two that are poignant to both your experience as a clinician as well as back to Diana and Richard. So one's a comment, one's a question. I think they're tied together. So Katie was commenting that she would like to see NPC QIC lead the way in discouraging the answer fine when a parent is asked, how are you? And then the question follow-up, I believe this is by Omaha, is how do parents feel about answering the question, how are you, when they're in front of their kids? Like, how open can they, you know, can they really be? And is that some of why they're even saying fine? So I don't know if you all could talk about that a little bit.
This is Diane. Obviously it's Diane. You guys can see me. That was stupid. It's sort of like when we ask our kids, right? How was your day at school? And they say fine. You have to reframe the way we ask the question, right? So I think in part it's reframing how we ask the question, so that we don't get an answer of fine, and or if the answer is fine, we've got to probe it, I think, differently. But I think it's probably reframing the question, and being more explicit, you know, to get to the answer. Because if you ask your kids, how was your day? They're going to say fine. It's got to be, you know, you'd say with your kids, you know, tell me something that you enjoyed about today, or tell me the best thing about today, or tell me something funny that happened today, to get to something that's more substantive. And I think that, I don't know, Carolyn, maybe it's in your scripts, you know, maybe that's part of what we do, is give people those better prompt questions so that the answer doesn't allow for that one word answer of fine. In terms of answering those questions, being asked those questions in front of your kids, it's a very valid point. When the kids are little, and they're not understanding your answers, that's maybe okay. Although if it still doesn't allow you to be able to show emotion, because kids sense your emotion. So if you're talking about a toddler, they may not understand the substance of what you're saying, but they're certainly understanding your emotion. And so I do think there needs to be the ability to have those conversations privately. And I think that's very, very valid and a really good point. And I don't know how you do that in a clinic setting, but I think to get honest answers, there needs to be some privacy around those conversations. And I think to also say, you know, to assess how the child is doing, the child needs to be asked and the parent needs to be asked, right? Because the answers you're going to get could be very, very different. And so as the child is all the way through, you know, how are you doing? How it has to be, you know, and I don't know how you ask that question to, you know, are you feeling anxious? Do you sometimes feel sad? I think the child needs to be asked those questions, and I think the parent needs to be asked their perception about the child. Is your child ever angry? Do they seem over sad? Or, you know, I think they need to be asked those questions. I think that conversation maybe can happen together, but I think both need to be asked the question.
I usually don't ask the question, how are you, without first prefacing it with, many parents have told me that they feel this way, or this, you know, this can be very common. How about you? Or to what extent are you feeling this? Because then you're opening it up by normalizing it before you even ask. And I think you're a lot less likely to get fine. I'm okay. Usually when you say that, when you normalize it, they're like, oh yeah, I know. And it just opens up the door a little bit.
And it also needs to be tracked over time too, because, you know, physical health, mental health, sometimes you don't know how much worse you are than, you know, a month ago or 6 months ago, because it's also slight and incremental that, you know, you have to have that sort of snapshot of like, this is what I was feeling 6 months ago. You know, oh my goodness, I'm like so much worse now and I didn't even notice. So, I mean, that's one of the things that people say fine because they do think they're fine, because they don't recognize how bad off they are. You know, you see that with, you know, physical conditions, you know, heart failure. People don't know that they're sicker over slow declines over many months. And because you don't have any kind of reasonable benchmark to look at yourself, you know, it's not sudden. And, you know, if people did have, you know, sudden catastrophic mental collapses because of this, we would, you know, obviously be able to recognize them. But it's so kind of pernicious and slow and unfolds over months and years that, you know, people do need to have some, you know, long-term clinical tracking and, you know, some kind of questionnaires or, you know, some kind, you know, they made us keep a graph of Lucy's food intake for 6 months, you know, so we could, when they were a baby, so we could see, you know, what, you know, how that was going. Or maybe I just did it because I was neurotic about that kind of thing. But, you know, you wouldn't have been able to tell from one day to the other if Lucy's intake was better or worse. You know, it has to be documented. Somebody has to look at it. Somebody has to sort of offer a tool, you know, to identify and track it, and then recognize where the tipping point is that people need to have some kind of, you know, some kind of intervention. I did notice actually, you know, one of the comments about, you know, why, how you doing, fine is bad. Jenny Brand had a comment earlier about a tool that they have to, you know, really look a little bit more minutely about how your day was, you know, and maybe there's a clinical version of that that can be introduced into the, you know, the cardiology appointment so they can create some trackable data point about, you know, how fine you really are.
So Richard, just to follow up on that, the psychology fellow who works with me in cardiology has recently started testing a distress thermometer, and it's so simple, and she just does it as part of her clinical visits with families. But I think it's from like 1 to 8 or 1 to 10, and she has found that it just opens the door for conversations. And so she's seen a big difference in the families who she's met with post using that versus before, where she'd get more of the, no, we're okay, you know, we're hanging in there, versus, well, it's definitely not a 1. I guess it could be now maybe like a 5, but I think before it was a 7. When we had the surgery, it was this, and then we had this period of time. And so families are actually really thinking about it, and I think it helps them to sort of scale where they have been at different times. And so we just kind of decided to start using it, and she's found it to be great. So we don't have any data on the use of it with cardiac families, but we may in the future.
Perfect. And we have a lot of feedback coming in. So Innova Children's actually is giving a shout out today. They have an amazing life group that does a great, child life group, excuse me, that they feel like does a fabulous work with their cardiac patients, siblings and families. And Bianca's weighing in, and she says that she has an early intervention teacher who constantly is asking how he's doing emotionally, how his behaviors are, and then also asks her about herself and her scale of emotion. So this is getting done some. It's just, we also, it's interesting to think of back to the change package and providing strategies to continue to help with this. We had Jenny also weighing in that she'd like to have parent scripts to help communicate to providers. So is she really fine or is she not fine? And help open that bridge for open conversation.
Yeah, and I probably wasn't clear that we recognize there probably are some separate things. So Jenny will be reaching out to you for help with that. I think that was Jenny Bren, not Jenny Strawn.
You're right.
So okay. Reach out to both of them. So,
okay, awesome.
That's great.
So we have about 5 minutes left for closing out. If there are any closing thoughts in particular.
I would just say this is, for me, you know, the work we're doing is a work in progress. And thank you, Diane, Richard, and Erica, and then all the parents who've contributed, because I think it's really breaking some new ground that's really old ground. But for the clinical teams, I think we're really moving into something that's really important. So if you have other ideas, I'm going to look forward to reading the chat comments because I'm not online. But I just want to thank, again, Diane, Richard, and Erica, because that was really terrific. And thanks for everybody who's sending in thoughts and comments.